Oh, good evening, guys. Good evening, everyone. Welcome to the session. Thumbs up from anyone. If I'm visible and audible, all of you. I can see a lot of people around. So Dr. Julie says good evening. Yeah, all right. So we'll just start with the session, and I'm seeing your messages right in front of me. So okay, just give me a second, and then we'll start. We'll wait for more people to join in as well. For the new people, so I get Dr. Nana NEET PG. Good. So nice names over there. All right. So as I said, we'll just start with the session. I'll take about a minute or two to introduce myself. Dr. Rohan is also there. So this would be the fourth part of the NEET PG sessions that we are taking. I've already taken 1, 2, 3, and 4. The few questions there might have been repeats, and I don't think so. A lot of them have been repeats, but more importantly, the options are different from all of them. All of them options are different, and the way that we've set up today also we'll discuss the same thing. We'll discuss the MCQs and we will discuss the concepts on that. For people who have seen my previous sessions, good evening, Dr. Sushma. Very good to see you here also, Dr. Sushma. She's coming directly from the special class that I was holding. So good to see. And as I said, it will be MCQs plus concepts, and that's how I take. So all the people who think that I'm going to discuss 30 to 60 MCQs in this 1 hour, no, it's not like that. I'm going to discuss 10 to 12, 8 to 10, 12 MCQs, and I'm going to discuss concepts based with that. Okay. So that we have a clear understanding of the subject also. So I'll be just waiting for a minute or two for everyone to join in. And by then I'll just introduce myself to you. My name is Dr. Vinish Srivastava. Presently, I'm the head of the department and associate director of anesthesia and critical care. I'm working with the Fortis Lafam Hospital in New Delhi. Before this, I was a senior consultant here itself at Fortis Lafam Hospital for the last 8 years. Prior to that, I was at Maulana Azad Medical College. I was a specialist over there. I've also done my senior residency from Maulana Azad Medical College. Prior to that, I've done my DNB secondary anesthesia. That's from Deen Dayal Upadhyay Government Hospital, New Delhi. Prior to that, I've done my DA and FCPS from Grant Medical College, Mumbai, JJ Hospital. Before that, I've done my respiratory medicine from Lokmanya Tilak Municipal Medical College, Sion Hospital, Mumbai. Before that, I've done my hospital administration. That's from Symbiosis, Pune. And before that, I've done my MBBS. So that was a slight introduction about myself. Okay. So good evening, Dr. Zahir as well. In every class, I do make a point to say, apart from clinical duties and studies, please keep a hobby for yourself. For me, it's playing the guitar. Here, I'm playing it on the stage. I'm playing with a local folk band over here. Also been teaching students preparing for postgraduate medical entrance exams and FMG exams for the last 10 years now. Now I'm associated with Unacademy. So people who haven't followed me up, do follow. Thank you for all the dedications, guys, that you people send. It's a YouTube. People who haven't downloaded the app, please download the app. You have to use a code to get in. You can use any code that you have. Important just to let the new people know. Plus, courses are the ones which are subscription based. However, special classes are the ones which are free. This is the one class which I finished today at 3 p.m. and Dr. Sushma is coming straight away from there. Okay, right now in this class on YouTube. So this is where we discuss MCQs as well. And I discussed almost, I think Dr. Sushma, we discussed 8. Hi, Dr. Ali. Good to see you. Dr. Ali Raza again. Good to see you on YouTube also. After this, all those classes again, Dr. Ali Raza. Nice to see you. Yes. So it was just explaining everyone, for the people who are preparing, do download the app, and the special classes are the ones which are, the free sessions where we hold the MCQs. Okay. All right. Special class. Good evening, Dr. Mahesh. All the old people are also there. Good to see Dr. Mahesh also. Nice. Really nice. Good to see Dr. Mahesh again. All right. So special classes, guys, they are interactive, just like the subscription based. Polls are there. Even though special classes, remember, these are the free ones which are there on the app. Okay, you have a raise a hand feature, never miss a class, lecture notes, and you can attend them anywhere, anytime. Right, guys? Plus, courses are the one which are subscription based, and this is for long-term preparation, guys, where you have to preparing for, maybe for a year or two. This is where you need it. Okay. Dr. Mahesh is saying, hi, Dr. Mahesh. Dr. Mahesh says, yeah, Dr. Mahesh, I'm fine, doing fine. Dr. Mahesh says, I'm selected in AIMS Delhi. Congrats, Dr. Mahesh. Wonderful piece of news. So Dr. Mahesh, congratulations. I remember you've attended all the YouTube sessions. At least I remember all the special classes also. Thank you, Thank you, Dr. Mahesh. And you take care of yourself. Which branch have you taken? So good to see Dr. Mahesh. Nice. Really nice. Chalo, congratulations. Okay. So all the best to you. God bless. Do well. Okay. Do well, do well, do well. Okay, so guys, remember this is about the plus brace subscription. We have access to the question bank as well, right? Iconic is something that holds both Unacademy and Prep Ladder both at the same time. So you get best of both the worlds. Again, this is for long-term preparation. I said people preparing for a year or 2 years who want subscription based and still preparing. For other people, special classes and MCQ discussions are good enough. Even the YouTube sessions that we take are good, I feel, where we are discussing the concepts also, okay? Because courses are normally done in the plus part. Okay, question bank is highly effective. You get questions as well as explanations based on that. It is available on the plus platform and the iconic. So these are the things for the plus. This is for the iconic, depending on the kind of preparation that you people are looking out for. Congratulations to all FMGE toppers, all the people who have done well, part of Unacademy. And Dr. Mahesh, you should have given your name for AIMS also, na? We would have put your name as well, right? Anyways, congratulations, Dr. Mahesh. So raise a hand feature. I hope all of you are aware of this. These are the dates. Please mark your dates. If I don't tell you, how will you come to know? This is from the app. Once you download the app, so this is for the various tests which are there. 2nd February, 4th February, 1st, 2nd, 3rd, 6th, 7th, 8th. Please mark your dates, guys. Okay. These are the batches running. If I don't tell you, how will you people come to know? Because Unacademy is a platform where you tend to get lost. A lot of things are recorded over there. So these are the new batches which are coming up on the platform. All right. So this is ultra fast revision batch for a month. All right. Then you have the subject wise revision. This goes on for a year. Okay, guys. Again, subject wise revision. Again, a new batch from 1 year. Then there is high yield MCQ marathon batch. So all of us are there, part of different batches. Okay. So all the educators are there. Focus FMGE comprehensive batch and ultra fast NEET PG revision. Right. Today is the last day to unlock 20, which is 20% off on subscriptions. Today is Jan 31st. It's the last day today for day. So people who are looking for a subscription can go so. All right. Let's start with anesthesia. Oh, before I go there, people who haven't followed me on the app, please download the app. Do follow me up. And most important, we tell you to follow not because you come to know and there is a target of subscriptions as some people feel. This is what someone had sent me. Can I help you in completing your target of subscriptions? And I make it a point to discuss in all my classes. This is the answers we give. We have no targets. We teach because we enjoy teaching and students take PG by the seat of their choice. Okay. The aim is never ever subscriptions. Please realize this, guys. Okay. This is why I'm putting on a platform. There are a lot of people who keep on commenting. Can I help you in completing your target? No targets. The target is when people get PG seats and they thank us. Okay. This is what makes our day. After working in the hospital from morning to evening and then coming and taking a class, this is why we teach. Okay. This is the reason why we teach, guys. Okay. So remember that. These are the FMG students who have all mentioned, with anesthesia, who have studied, who mentioned me back. I mean, they got it back. So thank you for all these students who messaged me. Coming back to our sessions now. Let's start. I will take it in the form of poll. A lot of questions would seem similar. Please look at the options before you mark them. I'll be looking at the messages that you people are sending to me on the YouTube, and then we'll have a discussion. A critically ill patient is being transferred to another hospital and will need oxygen during this transfer. This oxygen cylinder is made up of. So there are 4 options to you. Please mark your answer. Polyvinyl chloride, aluminium, titanium, none of the above. As I said, you have to know the answer to mark it. These are all simple questions. They keep on getting repeated again and again. All of you would be knowing it. So someone has marked C. Yes, one answer. Other people, please mark your answers fast. Then we'll discuss it out. And I don't want to waste time on this question though. All right, so I'm getting answers C and B. No, yeah, C. Anyone else? Other answers, guys? So Dr. Sushma, you were there in the class last time also. Dr. Uday has given C. Dr. Sushma has given B. Dr. Julie says aluminium. Dr. VRD says C. Yeah, why is everyone so fixated with C? Ideally, the correct answer, okay, let me give you. Ideally, the correct answer is none of the above. Yes, Dr. Dinesh Dikshit there. Right. Dr. Dinesh Dikshit is the only one who gave that answer. None of the above. Remember, none of the above is the right answer. This was to confuse you. The same question. In fact, all of you attended my previous session. The same question I've asked, and all I did was forget this aluminium. In the previous question, I had written here molybdenum steel. This was last week, I think. And I had mentioned aluminium here. All I did today was take the same question. I cut molybdenum steel. I put aluminium over there and I wrote the answer as none of the above. Do you realize that's how questions come in the exam? And that's why we say always go through the last 5 years at least to come to know where they're concentrating on. So guys, coming to the point, this question over here, yes, cylinders are made up of aluminium, cylinders are made up of titanium. This is correct. But normal cylinder is not made up of aluminium and titanium. You get correct, Dr. Devanya Senthil Kumar. Correct. Normal a cylinder. See, what has it been written? MRI. It's written a critically ill patient is being transferred from one hospital and will need oxygen during the transfer. So basically, what is a normal oxygen cylinder made up of? And that is made up of molybdenum steel. MCQ question asked 1000 times. Thumbs up. Is it clear? The point is, you need aluminium or titanium when you have a MRI room. I discussed this last time also. In MRI, what you get is a magnetic field. Because of the magnetic field, that is the reason you will not use a normal cylinder made up of molybdenum steel, because it will get attracted to the magnetic field. Hence, for MRI room, you have aluminium or titanium. That is the point. Okay. Otherwise, routinely, all are made up of molybdenum steel. Okay, I think thumbs up I got. So hopefully this point is clear. Guys, remember that's how people confuse in exam. This is exactly. Yes, Dr. Mahesh, right. So aluminium and titanium, that's what I mentioned, are used for MRI. Okay, correct, Dr. Mahesh, absolutely. Aluminium and titanium are used for MRI. All right. Okay, everyone. So let's go forward. I hope this point is clear. Almost the same question I had asked last time. As I said, you can see it on the YouTube channel. The same thing is there. Just change in options. All I did today was I wanted to really ask that. Hence, I changed the options and asked you this question. Okay. So remember, that is how questions get made. So please pay attention, have your concepts clear, and then you'll get it. Remember, aluminium and titanium cylinders are there, but they are normally used for MRI. For all routine purposes, the cylinders are made up of molybdenum steel. Okay. And polyvinyl chloride is nothing but plastic. You don't have plastic cylinders. Okay. So this we don't have. Let's go forward to the next question. Hopefully people have understood this point. So all of the following can trigger malignant hyperthermia except. So halothane, thiopentone, succinylcholine, lignocaine. So please mark your answers. I'll be waiting for 30 seconds and then I'll discuss this out. Yes, guys, answers. Sorry, I took the tea also. I'm feeling cold a little bit. So chai le liya maine. I took a slight tea. So, I'm getting D. Someone marked it B. Dr. Devlina marked it B. Rest, Dr. Uday, Dr. Ali, Dr. Julie, Dr. Saurabh C, Dr. Nana, Dr. Dinesh S D, Dr. Sushma's B. Okay, so good. I've got different answers. All right. Correct answer? Correct answer is Dr. Let me name the two people. Dr. Devlina and Dr. Sushma, absolutely correct. It is thiopentone. Okay, simple question. A same question similar was asked even last year in NEET PG 2021 based on malignant hyperthermia regarding the channels. So remember, malignant hyperthermia is a genetic disorder, guys. Okay, halothane, succinylcholine or succinylcholine and lignocaine can all cause malignant hyperthermia. So what is malignant hyperthermia basically? It's a genetic disorder of the sarcoplasmic reticulum. Okay, it's a genetic disorder of the sarcoplasmic reticulum having the ryanodine receptor gene abnormality. Now, this ryanodine receptor gene is a calcium release channel. Okay, so routinely this patient will be normal walking, talking like all of us around. Okay, this patient will be normally talking, walking like all of us. But this patient has a genetic disorder. Yeah, so what have we got to do with anesthesia? The problem is somehow or the other when this patient having the genetic disorder comes for anesthesia and he gets exposed to anesthesia drugs. So basically this becomes a pharmacogenetic disease. Thumbs up. Is this point clear? It's a pharmacogenetic disease. Thumbs up everyone. Is this point clear? Which means this genetic disease gets pronounced or has its effect only when you expose the patient to those drugs. All right. Which anesthesia drugs? So if you expose this patient to halothane, You expose this patient, in fact, not to halothane, any volatile anesthetic agent, even if it is sevoflurane, even if it is desflurane, all of them, halothane, isoflurane, desflurane, sevoflurane, all of them, they will all cause malignant hyperthermia. But of course, maximum is halothane, no doubt. Or if you expose this patient to succinylcholine, or you expose this patient to lignocaine local anesthetic. Problem is, if patient is exposed to this thing, these drugs inside the OT, so therefore this patient comes inside the OT, I give these anesthesia drugs. So inside the OT, suddenly these drugs work at the ryanodine receptor gene, calcium release channel. It somehow or the other kind of paralyzes the channel, or something happens to the channel. There is huge amount of calcium release that takes place. Huge amounts of calcium release. Huge amounts. Because of this leads to increase in metabolism. Okay. It leads to electrolyte imbalance in the patient because calcium has got increased. Alright. So increased metabolism, electrolyte imbalance has taken place, and muscle rigidity, because this is a calcium release channel, sarcoplasmic reticulum in the muscle. So muscle rigidity also takes place. All the symptoms come because of them. Because of increased metabolism, you get increased carbon dioxide production. Okay, you get fever, temperature becomes increased. Because of electrolyte disturbances, you start getting arrhythmias in the patient. You get increased calcium, you get increased potassium. Muscle rigidity will lead to all the urine problems. You'll get myoglobinuria. All right, all those things in the urine will be seen. So these are the things that you see. All right, point is this temperature increases because this calcium channel has released. There is a continuous release of calcium taking place. This temperature keeps on increasing to more than 40, and the point is it does not decrease. Thumbs up. Is this point clear, everyone? Okay till here? Okay till here, everyone? Thumbs up, thumbs up. Yeah. Okay. So the point is now, so therefore, what to do in this patient? Only one treatment is there, and that is called dantrolene sodium. What is dantrolene? Dantrolene sodium is a drug that stops the release of calcium from here. Dantrolene sodium acts here, and it stops the release of calcium. So therefore, beyond that, whatever is gets controlled only by dantrolene that is given. So dantrolene sodium becomes the treatment of malignant hyperthermia. Dantrolene sodium is the treatment. Okay. And in case now this patient has become, we know it's a genetic disorder. This dantrolene sodium has saved his life. Now this patient comes for surgery again the next time. So he will come and tell you that I have this genetic disorder, which is malignant hyperthermia. Some doctor diagnosed me. He gave me dantrolene sodium for treatment inside the OT, and because of that I was saved. Okay. Then he comes for a surgery. So next time when you are doing surgery for him, and when you give anesthesia, you will not give him halothane volatiles, you will not give him succinylcholine, you will not give him lignocaine. So what will you do? For GA, the drug of choice becomes propofol, and for local anesthesia, the drug of choice is procaine. Thumbs up, all of you. Did you understand this? Correct. Dr. Anjali says propofol. Before that, Dr. Sujit said dantrolene. All of you, did you understand? That's malignant hyperthermia. All the questions are covered here. These are all the questions which normally come from malignant hyperthermia. Okay. Dr. Deblina, correct. Propofol. Yeah. Any questions or doubts, or should I go forward then? Hopefully all these points are clear to all of you. Okay. So that's malignant hyperthermia. All right. So here thiopentone is the one that does not cause malignant hyperthermia. Okay. But halothane can cause, suxamethonium can cause, and lignocaine can cause. They are not supposed to be used. So these three drugs are contraindicated. Okay. You are not going to use them in malignant hyperthermia patient. Okay. As I said, it's a pharmacogenetic disease. Right. So let's go forward. Next question. So a 40-year-old female is to undergo incisional hernia surgery. So nowadays a lot of clinical questions also come based on clinical. A simple question, and she's a known hypertensive. Which of the following anesthetic agents is contraindicated? I mean, the same question could have been asked in a simple manner. In hypertension, which agent not to use? But that's how questions come in exam when it is clinical based. Sort of a clinical scenario is given. You need to read it, and there are 4 options given to you. So please mark your answers. Which of the following should not be given in this patient? Dr. Julie, Dr. Ali, no, Dr. Abi, sorry, Dr. Deblina, Dr. Sushma. Other people? अच्छा, Dr. Nana has pressed एक time पे B has come the answer. Okay, so all of you 1, 2, 3, 4, 5, 6, 7. Dr. Kushal. All of you are correct. So if I'm getting 100% right over here, so that's what happens when you're taking an app in the special class app. Also, now I get the percentage. Right, Dr. Dinesh? All of you correct. Correct answer is ketamine. Okay. So remember, in hypertensive, what you will not give? Ketamine, because hypertensive already the BP has increased. When you speak of properties of ketamine, you speak of CVS. What does it do? Ketamine increases the blood pressure. Ketamine increases the heart rate. Ketamine increases the cardiac output. In fact, ketamine also increases the myocardial oxygen demand. Therefore, in any cardiac patient, ideally ketamine is contraindicated. Okay, so cardiac patient you will not give, but there are exceptions, except two conditions. One, imagine if someone's BP is 60/40 and you have to give general anesthesia. 60/40 means almost collapse, or let's take it 80/60. No, 80/60 is still okay. 60/40 kuch rahega. What will you give? You have to induce, you have to give GA. In those patients, I will prefer to use ketamine because it tends to increase the blood pressure. So if the patient is in shock, it becomes drug of choice, or if it is tetralogy of Fallot sort of shunt, this is where ketamine becomes drug of choice. Otherwise, ketamine in the complete cardiac system is contraindicated. Thumbs up all of you, point clear? Okay, I mean, thumbs up, यहाँ पे I know YouTube में thumbs up में time लगता है, but even then. Correct, Dr. Deblina, that's what I said. Cyanotic heart diseases is where you are going to, it will be a drug of choice. Now, propofol, guys, remember, when you speak of the cardiac system, it's going to decrease the BP, it decreases the heart rate, profound hypotension takes place. Midazolam, slight decrease in BP will take place, slight increase in heart rate. Normally, the cardiac output is kind of maintained, and that is why midazolam normally is used as a pre-medication drug. It's not an anesthetic agent. Pre-medication, basically it is used for producing amnesia. If you people know, it produces anterograde amnesia. This is why it is used, okay? And etomidate is the one which is used as ideally, because CVS mein ketamine is contraindicated, propofol decreases the BP so much. So if there's a cardiac patient, ideally the drug of choice becomes etomidate because etomidate maintains the cardiac output. So any cardiac patient, cardiac surgery, ideally the drug of choice for general anesthesia is etomidate. Okay, etomidate maintains the cardiac output. So hopefully these points are clear, guys, in this question. Let's go forward to the next one. Now, okay, so let's see. A 70-year-old female has to undergo incisional hernia surgery under GA. Okay, she is a hypertensive patient, has a past history of seizure, and is on various medications for her condition. Which one of the following drugs is essentially stopped before anesthesia in this patient? Phenytoin, clopidogrel, beta blockers, or statins? What is the one that you stop? Please mark your answers. As in, I can't hold it in a poll, but so I got Dr. Zahir marking an answer, Dr. Deblina, Dr. Hari, Dr. Ali. Okay, so I think all of you marked the correct answer, absolutely correct. Here it is clopidogrel. Remember, phenytoin is a drug that takes care of the seizures. Okay, so it is taking care of the seizures. If you stop the drug, it's possible that patient might throw up a seizure. So therefore, this you do not need to stop. Okay, beta blockers. It maintains the blood pressure of the patient. In case you stop it, suddenly patient's BP might increase or decrease or something might happen. Remember that something that maintains the physiology of the patient should not stop. Clopidogrel is not maintaining the physiology. Clopidogrel is a blood thinning agent. It's a blood thinner. It's making the blood thin. Problem is, if you do not stop clopidogrel, there are high chances of bleeding during the surgery because patient's blood is thin, and that is why clopidogrel normally is stopped. Clopidogrel is stopped 5 to 7 days prior to surgery. Okay, thumbs up everyone. Point clear? So because of increased chances of bleeding is where you will stop it. Statins, again, they kind of they are used as drugs to decrease the cholesterol levels. So they are maintaining the physiology. You do not stop. So do you realize the drugs which normally try to maintain the physiology are not stopped? So therefore, CNS drugs, CVS drugs, or drugs like respiratory medicines, they normally are not stopped. They are not. Patients are continued. You will want to stop drugs that increase chances of bleeding, drugs that cause lot of drug interactions like MAO inhibitors and lithium. Okay, drugs that increase chances of DVT, thromboembolism, like estrogen and all. So that's why OC pills need to be stopped. All right, smoking and all, which affects the respiratory system, but none of those drugs that maintain the physiology is stopped. So these are the kind of drugs which stop. Plus, because the patient is fasting, that is why all those blood sugar medicines need to be stopped, because our patient is fasting. Thumbs up, everyone clear? So in general, these are the kind of drugs that we need to stop. Rest everything is continued before the surgery. All right. All the things that maintain normal physiology is continued. Okay, thumbs up everyone. Point clear? And that was on PAC. Now kindly identify what is this? Three, 4, 5, 6, 7, 8. So if I get 8, 10 people right, which means all of you are absolutely correct. This is what is called as the Neuromuscular Monitor. Absolutely correct. This is not the bispectral index, not the electromyogram. All of them have electrodes. Can you see? These are electrodes placed here, but they are placed on the ulnar aspect. Okay. So basically this is a neuromuscular monitor. You are monitoring the, correct all of you. B wrong hai, Dr. Zahir. This is not bispectral index. So Dr. Zahir, bispectral index is this. This is bispectral index where you have electrodes placed on the forehead. Okay, so this is bispectral index. This is what is neuromuscular monitor. It monitors the nerve and the corresponding muscle. Okay, so adductor pollicis is what you will try to see the response at. So this is the ulnar nerve, neuromuscular monitor. So ulnar nerve is the most common nerve. The most common muscle used is the adductor pollicis muscle to see the response. This is what is called as an electromyogram. Okay, EMG. This is what you have studied in physiology. Okay, electromyogram, guys, is normally ideally supposed to be the gold standard or the best method to monitor the neuromuscular junction, but it is clinically not used. So clinically, what is more often used is the neuromuscular monitor. This is what is used clinically, okay, to monitor the neuromuscular junction. In the neuromuscular junction, the most common nerve that you monitor is the ulnar nerve. The most common corresponding muscle is the adductor pollicis muscle. The most common mode, most common because all these questions are asked in exam, is the train of 4 mode, where you get a 1, 2, 3, 4 stimuli. So when it is a non-depolarizing block, you get to see something called as fade. With a depolarizing block, you get decrease in height. Okay, so this is train of 4. The most common mode is train of 4 mode. Bispectral index is basically something that tells you about the depth of anesthesia monitoring. Electromyogram again tells you about the neuromuscular junction itself, but it is this one, the one that you see over here. Okay, this is electromyogram. Alright guys, let's take another question then. This is bispectral index. It tells you depth of anesthesia. How deep is the patient under anesthesia? So as you can see here, the patient is intubated. He is under anesthesia. So how does this monitor work? It tells you a level, it gives you a level between 100 and 0. So if our patient is awake like this, if the patient is awake, then the value will be around 100. But if the patient is totally deep, then how much? It depends. 100 matlab is awake, 0 matlab patient is means the patient is almost in coma. A value of 45 to 65 is for GA, a value of 65 to 85 is for sedation. So therefore, in a patient like this who's intubated, undergoing GA, I want the value to be between 45 to 65. This is what tells you the depth of anesthesia. How deep is the patient under anesthesia? Thumbs up everyone, clear? Are you clear? So we take the next question. All of you? Yes. Which of the following produces the maximum greenhouse effect? So Dr. Sushma gave a thumbs up for the previous one. The next question over here. Maximum greenhouse effect. So ether, enfluorine, halothane, nitrous oxide. So I'm getting answers halothane and nitrous oxide. So halothane and nitrous oxide. Then again nitrous oxide. Dr. Devlina says nitrous oxide. Dr. Smith says nitrous oxide. Okay. So remember, all the inhalationals, all of them do produce greenhouse effect. Yes, they do. Okay. But the maximum that produces greenhouse effect, guys, is correct. As you said, most of you are right. It is nitrous oxide. Nitrous oxide. That's the property. Nitrous oxide, guys, is supposed to be a greenhouse gas. Greenhouse gas means, what is it doing? It is decreasing the ozone layer. It is causing environmental pollution. The point is, nitrous oxide was a gas which was discovered in 1773. Today is 2022. We are still using it. Why? It works as a carrier agent. And that's exactly the reason, because it is causing so much environmental pollution. Okay, OT pollution, environmental pollution, it decreasing the ozone layer. So people are doing on a research on a new gas to work or to take its place, and the new gas for that is xenon. Okay, that's exactly why people are doing research on xenon, so that it can replace nitrous oxide as a carrier agent. Okay, so nitrous oxide is the one which has the maximum greenhouse effect. And apart from nitrous oxide, the next inhalational which is desflurane. Desflurane is also said to have greenhouse effects, just like nitrous. So nitrous and desflurane, they are the maximum out of all of them, greenhouse gas. Okay, clear? So I think let's thumbs up all of you. Is this point okay? I think so. So let's go forward. If there are any questions, you can ask me, guys. All right. So this is a procedure being done. Image based questions also there. So you'll have a question like this. So which of the following is best used for the procedure being done? So Dr. Devlina has given an answer. Dr. Nitin, Dr. Julie, Dr. Devanya, Dr. Sushma, Dr. Abhi. Okay, so almost 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Almost 10 people I got. Correct answer, yes. All of you are right. Till now, everyone has marked it C. Correct. The correct answer is C. Halothane, these two are inhalationals you will not use. The only point is that if people would be thinking about etomidate. Okay, so etomidate again is not used at all. Not here. Thiopentone. Howsoever, if the question would have been changed and would have been asked in such a manner, which is the drug of choice for the procedure being done? In that case, guys, the correct answer becomes methohexitol. Okay, methohexitol. Right, Dr. VRD. Correct. Dr. Julie says thiopentone neuroprotective. No, Dr. Julie, but that's not the reason behind it. Ideally, the drug, that's what I'm trying to come to. The drug of choice for this procedure is methohexitol, and the reason is that methohexitol is a proconvulsant drug. Now, methohexitol is the same group as thiopentone. So if I have to say thiopentone and methohexitol, both are barbiturates. Okay, so barbiturate is the same group as that phenobarbital that you people must be knowing. So phenobarbital, which is used in epilepsy. So of course it is neuroprotective. So similarly, you'll find thiopentone also anti-epileptic and neuroprotective sort of a thing. I mean, a correlation to remember. Methohexitol, on the other hand, though it is a barbiturate, just like phenobarbital, but no, Methoxytol, contrary to thiopentone, methoxytol is a pro-convulsant drug. It causes seizures. Then who will want to use it? ECT. ECT you will use it. ECT ka full form, what is that? Electroconvulsive therapy. So you want convulsion to take place. You want seizure to take place. Methoxytol is helping in that. So ideally, the drug of choice for ECT is methoxytol. Ideally. However, the problem is the side effect. And the biggest side effect that it has is the hypothalamus, pituitary, adrenal axis suppression. Hi Dr. Surya, good evening. Good to see so many people here. Good to see so many people, all old ones also. Very nice to catch them on YouTube. Okay, good evening. Alright, so this is HPA axis suppression, guys. Hypothalamus, pituitary, adrenal axis suppression. So the problem is with steroids, with catecholamines, and that is exactly why nowadays methoxytol, though being the drug of choice, is not used anymore. Also, another side effect is nausea, vomiting. Okay, another side effect is that. So what do we use now? So nowadays what we use is thiopentone. Though thiopentone is anticonvulsant, still we prefer to use thiopentone, or you can also use propofol followed by succinylcholine. This is what is used for ECT nowadays, electroconvulsive therapy. Okay, thumbs up everyone. Good evening, Dr. Tara Jeer. Dr. Tara Jeer. Okay. Good na? Today everyone is having good names. Huh? I like that fact. Otherwise everyone comes with that separate name. So difficult ho jata hai pehchanne mein. It is difficult to find out people, what names are written. Here we can identify all of you. So you can identify this also. What is there? The next one. Kindly identify. Yes, I did get a thumbs up from all of you. Thank you. So that makes me feel at least you people have understood or you're getting the points that I'm discussing. I'm just waiting for answers from all of you. Dr. Zahi, Dr. Sushma have given an answer. I could have made it more confusing, you know. I've given you the options. This could have been made slightly more confusing. Arey, kisne A mark kiya? Dr. Nana. But you know, people saying droperidol, I understand. People saying thiopentone, I don't understand. Why? So for that, those things are important. Okay, so let me go back to thiopentone. Here the correct answer is etomidate D. And why am I not angry but showing my thing, you know, displeasure at thiopentone? And the reason is because of thiopentone. Thiopentone, guys, is a powder. Thiopentone is a powder. If you will see, this is thiopentone. Thiopentone comes in a powder form. In fact, it comes as a yellow colored powder. Okay. Dr. Dinesh says etomidate white. Correct. White disappeared. It disappeared. Now not visible. Arey, Dr. VRD, not sorry. You should make mistakes here. Dr. V. Arey, you could write your full name na. Otherwise, I'm calling you Dr. VRD. कैसा लग रहा है ना सुनने में? See, if someone has to make a full form, na, they can change it or some kind of disease. ऐसा नाम लिखो ना. You must be having such a wonderful name. Imagine I change my name into something else. You know, there are so many names I can think for myself. You know, next time they will. I tell you all my classes. Imagine I keep for myself. Oh, the doctor with cup. The doctor with dash. You know. So, anyways, don't worry. Do not say sorry here. The point is, it's fine. You have to make mistakes here so that your doubts get cleared. That's what I want. It's nice. So remember, thiopentone comes as a powder. It's a yellow colored powder because it contains sulfur. Thio is sulfur. All of you remember? 12th standard chemistry. Yellow powder. Therefore, whenever you use thiopentone, you have to, it's an IV drug. So you have to mix it with something. You are going to mix it with normal saline. Whenever you mix it with normal saline, you make a concentration which is 2.5%. Always 2.5% is used when using thiopentone. It comes as a powder. Therefore, another property is that because it's a powder, it has a tendency to precipitate. Remember this with thiopentone. Alright. Even if it precipitates, guys, it's not going to look like this white in color. So white in color, basically, if I will say, like this kind of white are two drugs. The most important one which you people already know is propofol. Most of the time, in fact, I had not given that option at all. That's why people got confused. Propofol is white in color. But do you see this? Etomidate itself here, can you see it's an emulsion? This is also white in color. So remember this point, do not get confused in exam. Both propofol as well as etomidate come as emulsion and emulsion. Both are emulsions and both can be white in color. So please look at your options before you mark in exam. It is not always propofol which is white. There's another thing which comes white in color. Of course, you don't keep it in a syringe. You people must have seen that bag of total parental nutrition which is there in the ICU, which contains amino acids. Yes guys, even that amino acids and lipids. So all that bag is also white in color. It is just white like this. Okay. So remember, this similar sort of white would be propofol, would be etomidate, and in case that TPN lipids which are there, they would also look white, but they will come in a bag, not in a syringe. They will come in a bag of sort of 100 ml, 200 ml, 500 ml sort of thing. Propofol will be in a small vial which is given for anesthesia. Same thing holds true for etomidate also. Thumbs up all of you. Point clear. Hopefully you've understood this question. All of you okay? Achha, so let me take the next one. A patient while getting a dose of muscle relaxant for surgery complained of intense pain. Okay, which one of the following is most likely responsible? Yeah, thank you guys for the thumbs up. With thumbs up, I understand that you people understood. So let's take the next question and you guys can mark your answers and we'll discuss it out. Okay, so I find D and C as the answers right now. Okay, C and D. Other people? C, C, D, D. I'm getting some Russian also. Russian name. Is it Russian? I don't understand the language, but I understand. Anyways, this looks something. What language is that? I didn't understand. Dr. Nitin says C. Okay. So I think 1, 2, 3, 4, 5 people have marked the answers. Let's discuss it out. Yes, the correct answer is rocuronium in fact. Okay. Rocuronium rula deta hai. Rona. Okay. So point is muscle relaxant that has pain is only one drug and that is rocuronium. It's a property. Pancuronium is a drug. Okay. So when you are classifying muscle relaxants get classified. Dr. Surya says C. Right, Dr. Surya. So muscle relaxants, guys, are classified into two types, right? One is non-depolarizing, other is depolarizing. So depolarizing, you have only one drug called succinylcholine. In the old times, it was decamethonium. Nowadays, this is not clinically available. Non-depolarizing, based on structure, major classification is aminosteroids and benzyl isoquinolinium compounds. So aminosteroids, guys, are those drugs which normally have that onium behind them. So you will have the pancuronium, pipecuronium, okay, vicuronium, rocuronium, rapacuronium. Benzyl isoquinolinium compounds will be doxacurium, DTC. You'll have atracurium, cisatracurium, mivacurium. Pancuronium is a drug which increases heart rate, increases BP, causes arrhythmia. Pipecuronium is a cardiac stable drug. Vecuronium, again the most cardio-stable agent, and that is why vecuronium is the most common used because it is cardio-stable. Rocuronium is a drug, guys, which out of all the non-depolarizing right now is the fastest acting. That is why it is one of the drugs used as drug of choice in a full stomach patient. You know where succinylcholine is contraindicated, that is where you will be using rocuronium. Rocuronium, other point is that it increases heart rate. Okay, pancuronium increases the blood pressure also. Rocuronium increases only the heart rate. And the third thing is that it causes pain on injection. So these are properties of rocuronium. However, there was one drug which was supposed to be even faster than rocuronium, that is rapacuronium. In fact, this was the fastest acting. However, the problem is histamine release. because of histamine release, now rapacuronium is not used. Okay, it's not clinically available, and that's why rocuronium is the next fastest agent. So it is used in drug of choice in full stomach patients. Okay, so these are the properties of rocuronium: fastest acting, increase in heart rate, and causes pain on injection. On the other hand, histamine release is seen with rapacuronium. Histamine release is seen with DTC maximum. Atracurium again histamine release. Mivacurium again histamine release. And because atracurium releases histamine, that's exactly why they made cis-atracurium. It has no histamine release and no metabolite production, which can be used in seizure patients also. Okay, everyone? Clear? So this was in short, muscle relaxants. So we discussed kind of properties which are important, the questions on which, exams, these people ask questions again and again. Of course, you cannot finish the whole thing over here, but at least we discussed important properties of each one of them, including the classification. All right. So kindly identify the next one. Okay, thank you for all the thumbs up, guys. Thank you. So that I understood that you people have got the point. So let's take the next question. Okay, so this is one of my favorite questions, and the reason being is that every year some or the other question definitely comes from spinal or epidural. In fact, in NEET PG this time, as well as in FMGE, both the times they asked question about spinal and epidural regarding the same thing. So it may be a picture based diagram, or it may be because of related to anatomy. Any question can be there. Most of you are absolutely correct. In fact, all of you. I don't think anyone made a mistake. This is a Tuhi needle, and Tuhi needle is what is a Tuhi needle? It's a epidural needle. What is LP needle? It is the spinal needle. So remember, guys, spinal needle can be of two types. One is cutting, other is pencil tip. Okay, so cutting needle is something which will be like this, bevel shaped. Okay, bevel shaped cutting needle. Pencil tip needles are like this. Okay, so if you're puncturing the dura with a cutting needle, you get a dural rent which is like this. When you puncture with a pencil tip needle, you get a point which is like this. So therefore, the cutting needle has more chances of PDPH, post-dural puncture headache, because there is more CSF loss happening. In case of a pencil tip needle, there is less CSF loss. Therefore, there are less chances of PDPH, and that is why pencil tip needles like Whitaker are preferred, and they should be used so that the PDPH does not take place in patient. And PDPH is post-dural puncture headache, which is one of the complications or side effects of spinal anesthesia. In fact, PDPH is said to be the most common delayed complication of spinal anesthesia. Thumbs up. Is this point clear, all of you? This was about spinal needles, cutting and pencil tip. IV cannula, all of you already know. So when we speak of IV cannula, all of you, so IV cannula comes in various sizes. So you people know that it can be orange in color, it can be gray in color, it can be green in color, it can be pink in color, then it will be blue in color, it will be yellow in color, and it can be purple in color. Orange is, guys, called as 14 gauge, gray is 16, green is 18, pink is 20, blue is 22, yellow is 24, purple is 26. Pink is the most common used, and this is what we commonly use in adults. Green, guys, normally imagine if there's an adult coming in emergency, you want to give fast fluids, then this becomes the one that you will give, fast fluids. Blood transfusion. So these two are then normally used if you want to give fast fluids or if you need to transfuse blood. Orange normally is not available. Okay. Blue again is used in adults, but for small procedure, minor procedures, this is where it is used. Okay. Yellow. Yellow, guys, is normally used in pediatric patients. Purple is what is used in neonates. Now flow rates. So pink is almost 50 or 54, I will say. Blue comes to 33. Yellow, you get 20. Purple, I don't remember anymore. I don't remember purple. Green is around 88. Gray is around 180. Again, orange, I don't remember. Okay. I don't remember orange. So these are the ones which are normally asked in exams. So they will ask you about the pink. They will ask you about the blue. Yellow, they may ask. Purple, I don't remember. So I'm sorry for that. I don't remember right now. And there may be few changes in the values, but they are almost like this. So pink is around 54 ml per hour. Blue is around 33 ml per hour. Yellow you will find around 20 ml per hour. That's going in pediatric patients. And green, because you need a higher flow, it's going around 88, and gray is around 180 ml per hour, where you want to give blood and all. Okay, so that is gray. Right? So Dr. Julie, all right? Everyone comfortable? So that's with IV cannula, the various numbers and the flow rates which are there. All right. There may be few discrepancies in number, like this 180 can be 182 also, but this is the way that I remember. So, all right. So there may be, in case there are any discrepancies, then I'm sorry for that. All right, because these numbers are not very easy to by heart, but normally this is the way it is. Routine, almost this is how it goes. Okay. Then we talk about epidural needle. So epidural needle, as you can see, the one which is in front of you over here, epidural needle, it has got 1 centimeter marking. So it has 1 centimeter marking so that you come to know how far you are from the skin, because when you're going to the epidural space, unlike the spinal where you will go completely inside, epidural is slightly outside, na? So you're not supposed to go that deep. You're supposed to stop a little bit outside itself, and that is why you get that 1 centimeter marking, so that you know how deep you are inside from the skin. Because normal, the epidural space from the skin, so if this is the epidural space, so from the skin to the epidural space normally is 5 centimeters. So you got this 1 centimeter marking for you to know how far you are from the epidural space. Okay, that is how you understand this epidural needle. So this is your epidural needle. Also, the tip of the epidural needle, this tip of the epidural needle, it is curved. It's called a Huber tip. And you can see this epidural needle is thick, so that you can pass a catheter from within and the catheter can be left in epidural space. So compared to a spinal, what happens is when you're giving spinal anesthesia, you will give a drug, it will be single shot. You will deposit the drug and take the syringe out. However, in epidural, you will try the epidural space, you will find it, and you will put a small catheter inside. Okay, and from the catheter, you can have a continuous infusion which is going in. That is why spinal anesthesia is basically used for anesthesia and then surgery after that, and epidural, guys, is more commonly used for analgesia or pain relief. Okay, you put a catheter inside, and from there continuous infusion can be given for 2 to 3 days. That's exactly why THR and TKR are possible nowadays. You know, total hip replacement, total knee replacement. That is why it's possible. The same thing is important, or the same thing is done for labor analgesia or painless delivery. Thumbs up, everyone. Clear? So spinal, epidural, needles, I think we have discussed all that also. Important points here. All right, all of them are important. Okay. Now, during posterior fossa surgery, the surgeon says that the blood loss to the brain has increased considerably and the patient is bleeding. He wants the BP to be reduced. Which one of the following agents can be used to decrease the blood pressure in this patient? Please mark your answer. Thank you all of you for your thumbs up. So hopefully people have understood the points that we discussed till now. Okay, so next question is, during posterior fossa surgery, the surgeon says, oh, typing error. Today only I was typing this question. See, I made double S. When I was sitting in the hospital, I was doing this today. Type error, type error. It happens, no? That's how typing errors happen. Okay. A question like this I had said the previous time. If you go through my previous videos on YouTube or the special class, you'll find a similar question like this, but here the question is changed and the options are changed. Okay. So posterior fossa surgery, surgeon says that the blood supply to the brain has increased. Patient is bleeding. He wants to be reduced. Which of the following agents can be used? Yes, guys. Correct. So Dr. Nitin has given, Dr. Nitin, Dr. Abhi, Dr. Kushal, Dr. Devanya, Dr. Hari, Dr. Sushma. Okay. So, most of you are correct. Dr. Sushma, see, let us discuss this point out. That's why this question is important. Okay. And as I said, you guys can make mistakes here, which is good enough. Don't make mistakes in exam. Okay, that's the whole point. So here we can discuss it out. In fact, someone makes a mistake, that's better. Etomidate, remember, it maintains the cardiac output, I just told you. Okay, so there is no decrease in blood pressure. There is no decrease in heart rate. It maintains the cardiac output. If you see ketamine, it increases the blood pressure. I just discussed, it increases the heart rate. It increases the cardiac output. Okay, if you look at propofol, it decreases the BP, it decreases the heart rate, it decreases the cardiac output. Okay, so therefore you want a drug that has to decrease the BP. Will you use etomidate? It is not decreasing. There's no change in heart rate, BP or cardiac outputs. Therefore, the correct answer is propofol, decreasing the BP, decreasing the heart rate, decreasing the cardiac output. Clear, everyone? Thumbs up. Point clear? Okay, simple question. This was a simple question, but that's how questions come in exam. All right, simple one. Okay. So next question. Kindly identify what is this. I got a thumbs up from all of you, so thank you. Next, let's take the next one. So B, I'm getting B and D and D and B and D are the two options I'm seeing. Okay. Sorry, I twisted myself there because I've kept the phone on that side, the YouTube. So I'm seeing it over there, the responses that you people are giving me. So most of you have marked it as D. Absolutely correct. Absolutely correct. So that is the arterial line. Can you see the backflow of blood happening because of the huge pressure? Slight backflow is also there. Of course, a little bit can happen in the IV line also, but the pressure in a arterial line is so high. So this is what is called as an arterial line. Arterial line is inserted in an artery. This is the radial artery. Okay. When you speak of lines, this is where you want arterial line is what is put in inside an artery. The most common is used is the radial artery, or you can use the ulnar artery. You can also use the brachial artery. We can use the femoral, and we can use in the leg dorsalis pedis. Sorry for my handwriting. I write like doctors. I'm sorry. I'm trying to improve my handwriting. My parents tried to improve that from childhood, but I could not improve. Hence I took up medicine. Anyways, radial artery, ulnar artery, this is brachial artery. Okay, so these are the places where you put for an arterial line. Then I said there is femoral, and in the leg there is dorsalis pedis. So this is the place. Remember, all of them are artery, 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 and artery. This is where you put an arterial line. An arterial line is what is called as invasive blood pressure measurement. This tells you beat to beat blood pressure measurement. You must have seen this tuck, 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 this dichrotic notch and all, which you must have studied. It tells you beat to beat blood pressure measurement. How much is the BP? Okay. And the arterial line also tells you or gives you a sample for arterial blood gas sample. Remember, these are arteries. Central line is put in a major vein. So when you put a central line, guys, it will be put inside the internal jugular vein, IJV, or you will have the subclavian vein, or you can use the basilic vein, or you can use the cephalic vein, or you can use the femoral vein. Do you realize these are all veins? So therefore, arterial line lies in an artery. It tells you invasive blood pressure measurement with every beat, not non-invasive, it is invasive. And central line is put in a major vein of the body. It tells you basically the fluid status of the body or the CVP. Normal CVP is 8 to 10 centimeter of water. Okay, normal CVP. Apart from that, you can give vasoactive drugs from there. You can give, chemotherapy drugs from there. It can work as a dialysis line. You can do blood collection from there. Okay. So that is central line. It tells you basically fluid status, CVP, chemotherapy drugs, vasoactive drugs. TPN can go from there. Dialysis line, dialysis can happen from the same thing. So that's the difference. Central line lies in the vein of the body. Arterial line lies in the artery. Okay, one measures the basic blood pressure, beat to beat blood pressure, invasive methods, and the central line is to measure the fluid status or the CVP of the patient. Okay, what is the fluid status? Okay, so thumbs up, guys. Everyone, did you understand? Any questions, any doubts, please do ask me. Thank you for joining me at this session. So next month again, I'll be coming with more sessions. People who haven't downloaded the app, please do download the app. Okay, and follow us so that you come to know when our next sessions are held, so that you would come to know. All right. Yes, guys. Thank you for joining me at the session, guys. Any questions or any doubts? Just wanted to ask all of you. Dr. Julie says most common complication of central line, CVP line. So CVP line depends on where you're inserting. It can be, so there are a lot of them. It depends whether you're inserting it from which side, whether you're putting it from the internal jugular, subclavian or femoral. However, the most common complication that you see with internal jugular or subclavian is a pneumothorax. Okay, apart from that, there can be hematoma. All right, so that's Dr. Julie answer for you. Thank you, Dr. Sushma. Thank you, Dr. Veer. People who haven't downloaded the app, please download the app. All right, and so that you are there on the app as well, and you people come to know when our sessions are held, so that you can follow us, and whenever we are holding the next sessions on MCQs or whatever. So remember, the special classes are the free classes. So people who are just preparing MCQs can attend the special class, and we can have discussions based on them, just like we had it over here. And plus is basically for subscription, people who are preparing long term and want complete courses. Okay. Thank you, Dr. Kushal. Thank you, Dr. Veer. Thank you, Dr. Sushma. Thank you everyone for joining me at this session. So I'll take your leave. Thank you. All right. Any questions, any doubts, you can ask us directly. You can also use that community app. On the Unacademy, there is some community. You can type us questions directly and ask us. You get in touch with us directly on that. So we can type you then and there itself. It's like WhatsApp or Insta. Okay. The community on the app that we have. It's like Instagram. Dr. Julie says there was a question this year regarding CVP line. Left side and right side complication difference. Dr. Julie, I don't remember that question because I went through the question paper. You're talking of NEET PG. You ask us the question directly. Okay? Just send it forward to me because I remember. Dr. Nana says, sir, in dialysis, when patient's BP decrease, how to overcome it? Medicine question. Medicine people are better people. If rather than me giving you a wrong answer, it's no point. Na? Okay. Medicine people will help you better. Okay. If I give you a wrong answer, doesn't make sense, Dr. Nana. Dr. Julie, chylothorax or pneumothorax? It's not chylothorax, Dr. Julie, it's pneumothorax. Left and right side. I didn't understand the question, but normally pneumothorax is more common, which is seen. Okay. So if there's a complete question, you ask me that directly, but otherwise pneumothorax is the most common complication of the central line that we insert. Okay. All right. All right. Right, Dr. Nana? I don't want to give you a wrong answer. Yeah? It doesn't make sense for me to give you a wrong answer, especially regarding dialysis, because it's much better if you ask when we are doing medicine and nephro is getting covered in that. A lot of things are important in nephro. If I give you a wrong answer, it doesn't make sense. Dr. Hari says short discussion of reversal agents of muscle. Itme time lag jayega, Dr. Hari. We'll come again and discuss more MCQs the next time around. Okay, don't worry. Okay, Dr. Hari. Otherwise, I'll have another session on the special class MCQs just based on muscle relaxants. That's what we want. Now you tell us a feedback. We'll hold the classes accordingly. Once you give us a feedback, we hold the classes depending on what kind of classes you want. Okay. So the next time I plan my class, we'll have maybe just MCQs related to muscle relaxants. Okay. We'll try to do that. Fine. So hopefully that will take care of as Dr. Hariharan has said. Okay. Thank you all of you. Yeah? Thank you so much. Thank you. Thank you, Dr. Surya. Okay. And thanks, Dr. Julie. Thank you all of you. Bye. Take care. All the best. Do well.